Hi everyone. Good evening and a very warm welcome to MBIOSymposium 2020, a global pandemic. I'm Melissa Tan and I'm a second year biomedical science student from the University of Sheffield, and I'll be your MC for today. So I'll start with a brief introduction about Malaysian Bioscience Scholars, more commonly known as MBIOS. So founded in 2017, we are a student-led organization which aims to serve Malaysian students in the pursuit of bioscience careers all around the world. And we do this by providing a platform for all bioscience students to network and host events to enhance employability in the field of bioscience. So MBIOSymposium is an annual flagship event of MBIOS, which aims to promote intellectual discourse among young generation about current issues. So hosting this event this year wasn't easy for the MBIOS committee because of the pandemic. So we opted to host our first ever virtual MBIOSymposium. So this is when we realized that COVID-19 has affected every single person in this world in many different ways. So we decided that it is very timely for the theme of this year's symposium to surround COVID-19. So this weekend, we will be having 10 esteemed speakers from many different fields to talk about how they have been personally affected by COVID-19, with the hopes of educating our participants about the local and global impact of COVID-19. So our aim today is to inspire students to be more aware of the industry before embarking onto their journeys of building their own careers. So of course, this event could not have been made possible without firstly our sponsor, AstraZeneca Malaysia, our speakers who have generously taken time off their busy schedules for this event, our media partners, Science Media Centre Malaysia and 100 Scientists of Malaysia, and of course the MBIOS team who have worked tirelessly throughout these past few months to make this event possible. Yep, so without further ado, we'll get started with the opening keynote for our event by none other than our very own Director General of Health Malaysia, Datuk Dr. Noor Hisham Abdullah. So since the COVID-19 pandemic, Dr. Noor Hisham has been known worldwide for his outstanding efforts in containing the COVID-19 in Malaysia. Appearing regularly on television to give the latest updates on the outbreak, Datuk has become a symbol of hope and comfort that Malaysians cling on to throughout this tough period. Also a senior consultant surgeon in breast and endocrine surgery, Datuk has stolen the attention of many people around the world and won prestigious awards for his efforts. So without eating up any more of your time, it is my absolute pleasure to invite Datuk to deliver his opening keynote. Over to you, Datuk.
For having me today, and certainly this is a good opportunity for us to share experience, and perhaps I would like to start with a short presentation and open up to more time for questions and answers. And to start off, the global trend of COVID-19, cumulative confirmed cases to date, we have more than 20.9 million people been infected, and deaths are almost 755,612 deaths been documented, affecting almost about 188 countries. And this is indeed a real challenge for us. And it all started in Wuhan way back in December 2019. And we were not in denial, but what we did is we prepare ourselves, activated the Crisis Response and Preparedness Center in HQ as well as all the states, and started to retrain our public health in terms of the past experience of organization, acute case detections, and streamline our IT system and etc. And what we did initially is we know that this is a new virus and we have no knowledge about this virus at all, but we need to fight this virus. And to fight this virus, we must be able to detect and diagnose the virus. So our lab, Institute of Medical Research, have prepared the RT-PCR well. And when the Chinese authority released the genomic sequence, so we prime our, we use the genomic sequence and prime our test, and we were able to prepare our lab for the testing of this SARS-CoV-2, whereby WHO at that point of time have not even released their protocol in terms of the testing. And we started to train our labs, public and the private sector, to be ready. We started with 23 labs, 14 in the public sector. And again, our capacity then was about 6,000, but we do not have any cases then. So that was on the early part of the January. Then also we looked into the experience of China and other countries, the 5 countries, namely apart from China, Japan, Korea, Italy, and Iran. And their hospital and the facilities overwhelmed the cases. And in fact, Italy have better facilities than us, but again, not able to cater for this increased number of patients in the hospital. So what we did is our hospital, as you know, is already congested with patients even before the COVID. So what we did is we decanned 7 of the hospital, to be a fully COVID hospital, and some of the services that we have moved lock, stock, and barrel to a district hospital, and so that they can able to continue to deliver services, for example, surgery and orthopedic and etc. So we have 7 hospitals for COVID patients, and we have 33 hospitals managing COVID and non-COVID patients. And also we built because we were preparing for the worst and hope for the best. So we got our exhibition center, a huge exhibition center in Sedang, MAIPS, and then we managed in 4 days, we built a 600 beds hospital in a temporary hospital to cater for cases. And our policy then and now is that we embrace targeted testing. That means we continue to do mass testing, but targeted to a locality and a high-risk group. So at least that we can actually identify more cases from this targeted approach. Second is that positive patient, even though they are asymptomatic or mild symptom, we will admit them to our hospital. Then thirdly is that those coming back from overseas is a mandatory quarantine. We started initially at home and then now in our quarantine center. These are some of the policies that we have. So next slide, please. So now you look into the next slide. This is the whole approach that we have initially based on the 6 principles. Number 1 is we realize that we need to have a strong border control. Mainly tighten our border control because we realize people are coming back. Malaysians returnees are coming back with infection, for example. Tourists is coming in with the infection. So border control is number 1. Second, enhance our facilities. So what we did is in terms of procurement of equipment, ventilators, because we realized that in other country, for example, they are running out of ventilators. So we had at the point of time we have 350 ventilators, but now we have 1,364 ventilators for COVID patients only. And also we innovated our ICU, CCU, PICU. We converted when we mobilized, decanned them to other hospitals. Then we converted this unit to become ICU. So we increased the ICU beds in a hospital like Sungai Buloh and etc. And third is that we enhance our public health intervention. So we have experience in the past for SARS, MERS-CoV, even H1N1. So when we look into it, we train our staff in terms of active case detection, the documentation, the system, and etc. So it's not a reactive, it is actually a proactive management. Fourth is that we look into the high-risk group and vulnerable society, for example, the orang asli, the longhouses. So they really take the action in terms of forbidding people to come in to visit the longhouses, for example. So they protect the green areas and the high-risk group, the elderly, for example, old folks home and all. So we make sure that those coming in, although sometimes they want to do charity work and etc., but they have to be screened. Otherwise, they will bring infection to the old folks home. So this is the 4th initiative. 5th is strategic communication, because there's a lot of fear in the public. So how do we manage the fear because of this new virus? So you need to engage and make sure that our public understand the virus, the consequences, and etc. So by understanding, then the fear will be less. So this is our management. We did identify 2 platforms of engagement. Number 1 is from the non-medical perspective, the Minister of Defense will address in terms of coordination with the police, immigration, the army, and etc. So Ministry of Health, I will engage with the public daily without fail in terms of sharing the data, inform the current situation, informed of the locality of the infection, etc. So this is a very important engagement whereby the public have also the opportunity for us to explain issues and challenges, Q&A, and etc. So by doing so, we continue to build expectation, and we create expectation of the public, and our job is to deliver beyond that expectation. So if we can deliver beyond that expectation in terms of testing, in terms of the facilities, in terms of the cases, in terms of the spread, then we'll build public trust. That is the most important. Once public trusts us, then it is the time for us to empower the public to take action, because this war cannot be won without the public participation. This is actually, you need a government, you need the public to come together as one. Then only we can win this war in time. Next. So now you look into these 6 principles that we have. Number 1 is that our principle before this is you have to look into evidence-based approach. When we engage with the public, we talk about facts, not reactive, not my opinion, but it is based on the facts. So we have protocol in place, we have testing in place, we have projection in place. We even have health technology assessment, looking into the new innovation, etc. So these are how we deploy to give trust to the public based on facts, not politics. We are overriding politics here. We are using facts. This is important. And most important is that the Prime Minister of the day listens and also trusts the civil servant based on facts again. So if the Prime Minister is not listening to us, and then that will be a beginning of the end of our fight of COVID. Then we advise initially we have a first wave. Our first patient was on the 24th of January, and our first wave, case number 1 to case 22, all related to Wuhan tourists directly or indirectly. So, and we know that today we did a virus study. Most of our cases from the first wave is from Wuhan. There is actually a strain B virus. And then we have 11 days, no patient at all from 16th of February until 26th of February. There's no patient. Then the second wave came in. The second wave came in is mainly from Malaysian returnees from Japan, from Korea, bringing the infection. So then we realized that, school holidays around the corner, and we were told that more than 10,000 of our Malaysians going for holiday during the school holiday. So, and if 10,000 plus their spouse and the children and all that, probably we are going to handle 30,000 cases in 1 week, bringing the infection back. How are we going to screen them? How are we going to isolate them, and etc. So what we did is, during that period of political turmoil and the new government came in, we advised the Prime Minister to take drastic action. Because at that point of time, we have a small window of opportunity to do it right, to contain the infection. Otherwise, it was a burning ember then. Otherwise, it will spread like a wildfire. Once the wildfire is very difficult for public health intervention to come in. Imagine, for example, you have 1,000 or 2,000 cases a day. How are you going to contact tracing each and every one of them? So that will be we need a lot of resources, and probably we do not have that luxury at that point of time. So what we did is we advised the Prime Minister to start on the movement control order, the lockdown. This is a very important decision. It is actually a very artificial environment. Everybody stays at home so that our public health intervention can be more effective and break the chain of transmission. So we started this lockdown, and we call it the MCO. So we have MCO 1, 2, 3, 4, and 5. 1, 2, 3, and 4. And then the idea of MCO was to flatten the curve, and we managed to flatten the curve, but at a cost. So we switched to the second strategy, CMCO, Conditional Movement Control Order. The CMCO is to allow the economic sector to resume back to normal, with the caveat to follow our SOP. And that is our second battle. And the third battle, once we realized that we managed to control the infection using CMCO, then we allowed the economic sector, the social sector, the sports sector, the education sector to come back in RMCO. So we have won the war of MCO, phase 1, 2, 3, and 4, because we managed to flatten the curve. That was the idea of the MCO. And this was projected by JP Morgan that you have 6,300 cases on the 14th of April. And Malaysian Institute of Economic Research projected that we have 8,900 cases on the 28th of April. But we proved them wrong. So our cases were way below 5,000. And we managed to flatten the curve, as you can see here. So once we have flattened the curve, we switch our strategy because the cost of MCO is very expensive. So we need to revive our economy. So we allowed the economy, the CMCO. And during the CMCO, it was a fasting month and the festive season down the corner. So we continue to monitor the cases and allow the economy to resume. But again, you can see the two spike in the CMCO. That was actually mainly from the migrants, the illegal migrants that we have detained them in our detention center, and a spike of 271 cases, for example. But nonetheless, they are contained, not out in the community. So we managed to flatten the curve, and we succeeded in MCO and CMCO. So once we have succeeded the CMCO, we move on to RMCO. So RMCO is to allow all sector back to normal, but follow the SOP. This is a normal situation, but everybody have to comply to the social responsibility, social discipline, and social compliance to the SOP. So we have won the war of, we have won the battle of MCO, we have won the battle of CMCO, and we are now in the battle of RMCO. But we have not won the war yet. But in between the MCO and CMCO, we have EMCO, enhanced MCO. In terms of certain area, for example, there's high outbreak, we came in, we locked down the whole area, and then we screen everyone, and test everyone, local, whether it's foreigners, illegal or legal, we test everyone, we provide food for them for 2 weeks. The positive cases will be isolated in the hospital, the negative and exposed to positive cases will be quarantined for 14 days. So once they have completed the 14 days, then the locals will resume back their normal activities. Likewise, the legal foreigners, workers, migrants will be released and actually continue their activities. But what do you do with the illegal, undocumented, migrants? So we have to detain them in our detention center and deport them back to their respective country. So now we are in the RMCO. Initially, we see the phase one, early phase of the RMCO, we managed to bring down the cases to double digit and even single digit. We have in 3 days, I think we have 0 cases. But towards the end of RMCO, then we realized that there were poor compliance to our SOP and cases coming up, increasing. So before the MCO, our R0 was 3.55, which means one person will infect 3.55 people. If you have 100 people are infected, you infect 355 people the next round, and that will continue to increase the cases. But we managed to bring down the R0 to 0.33, which means 100 people infected, they'll infect 33 people and continue to, the 33 people infect less, and this will bring down the curve. But during the mid phase of the RMCO, the R0 went up to 1.36 on the 24th of July. So we sound the alarm, and then we managed to bring down the R0 to R0, or you call it RTT, is a time, to 0.78. Today we are on the R0 RT is 0.78. Next. So if you were to look into our cases now, we have done more than a test, or more than 1 million tests, and our positivity rate is only 0.83. Our fatality 1.37. Recovery rate is almost 96.5%. And our active cases today, less than 200 cases, about 196 cases, they are been isolated in our hospital. And ICU, we have 4 patients ICU, 1 patient needed ventilation. We have more than enough capacity, 1,365 ventilators, but we are only using 1 ventilator. So we managed to flatten the curve, and you can see the active cases coming down. So far we are doing fairly well, but we need the collaboration. So the leadership is important here in terms of the whole government and whole society approach. Next. Now, if we were to look into this data from Oxford, looking into Malaysia, the test per 1,000 population, because there's a perception that we are under testing in this country. So we look into our data. Now, in terms of Malaysia, we have done 33.52 tests per 1,000 population, and our positive rate is 0.8. South Korea, they are doing 31.93 tests per 1,000 population. Their positive rate is 0.9. Thailand have only done 5.6, but their positive rate is also 0.9. Japan 8.5, positive is higher, 4.6. So there's a paper from WHO. If you detect more positive rate, 10%, 15%, that shows that there are more individual out there not been diagnosed. That means positive cases not been identified and diagnosed. So if you can actually bring it down to 0.8, which shows that we are doing fairly well, adequate in terms of our testing. Now you look into Singapore, for example, they are doing more than us, 117.38 tests per 1,000 population, but their positive rate is 8.1. Likewise, you look into United States, they are doing more than us, 195.2 tests per 1,000 population, but their positive rate is 8, which means they have to do more tests to pick up the cases. So this is something that, in terms of positive rate, when do we, in terms of benchmark, whether our test adequate or not. So in UK, they are doing 166 tests per 1,000 population, and the positive rate is 2.8%. Next. So, well, you look in our preparedness, so we started very early. We are not in denial. We know that in some point of time, maybe the virus will reach our shore. So we have been given 2 months, in terms of notification to prepare our team. So we came up with our whole holistic preparation based on what we learned from our past experience in the Ministry of Health. But we have to scale up in terms of the action plan, because this is a pandemic not only involving the Ministry of Health but other ministries as well. So Ministry of Armed Forces, Police, and etc. So basically, this is a whole government approach. So our every day we have meetings in terms of coordinating with Ministry of Health, the other ministries, and put up upfront the action plan to contain the infection. And we came up with the guidelines from first edition until now, because the virus, it's a new virus, so our experience very limited on this new virus. So our relationship, so every day brings new lesson and knowledge, and we continue to evolve and edit our guidelines. Next. So in terms of the capacity, you can see that our lab capacity, we started with 800 tests a day in January. Now our capacity is 38,636 tests a day. And our hospital screening 120, and COVID hospital we have 47. Basically 7 is fully COVID hospital, and 33 hybrid hospital. Our maximum beds in our hospital is 5,674, and ICU maximum critical care or ICU beds 442, and total ventilators we have 1,364. And also we are working closely, engaging with our partners in terms of mobilization of our human resource, equipments, and etc. And also, and we are looking into how to provide beds if you need it. So far, I think we touch wood, we are in the right, course of action. And our cases, you can see that ICU utilization in only 4 patients at the moment. Next. And you can see our war, our battle of MCO, battle of CMCO, and battle of RMCO. We managed to bring down the cases. And at the moment, I think more important is to maintain. So our challenge is, when we succeed, it breeds complacency, and complacency breeds failure. So again, we need a full collaboration and cooperation from the public to comply to the SOP, namely practice social distancing at least 1 meter, put on a mask, continue to wash your hands, make sure that you avoid public places, confined spaces, and also close conversation. So if you can have a conversation, make sure you have a distance. So these are some basic, messages to our public, but it's not easy to embrace and practice in the daily life. Next. So in conclusion, what's more important that our success is basically because of a teamwork, working together, a whole government and whole society approach. Second is continue to strengthen the preparedness and response capacity. We need to continue to, although cases are down, we need to continue our surveillance in our public and community, make sure that we tighten our border and continue to assess the situation from time to time. Enhance late containment phase, maximize the suppression of the disease transmission. That's important. Early detection of cases so that they can be treated early before they progress into a stage 3 or stage 4 or stage 5. Then behavior modification. This is the most difficult and challenging. That is actually to manage the expectation of the public, to conditioning the mindset of our public to comply to the SOP and follow the rules and regulation that we have. The most safest place will be at home. But you need to get out of your home, then you have to put on your mask and make sure that you practice physical distancing and continue to wash your hand. And we hope that you'll continue to strengthen the health system capabilities and also embrace digital readiness. So the lesson learned from this experience this far is that, we are prepared in terms of system, in terms of organization, etc. So if only we can get the IT system ready, for example, not reactive during the pandemic, but before you get the pandemic, you already have an integrated IT system, digital system, in terms of prediction, in terms of modeling, in terms of coordination. I think that would be the best. So that is actually lacking that we see, but this is a new era of using digital innovation and creativity for us to enhance our preparedness and response. And last but not least, to continue to strengthen the regional and international collaboration. So I think this is something that we need to work in our ASEAN platform, and then we need to work with our neighbors as well as globally. How can we, come together in unity to flatten the curve and to break the chain of COVID transmission in our country as well as regionally and globally. Next. So that's about all from my presentation. I think I have given enough time for questions and answers. So I welcome any questions from the audience.
Yeah, thank you, Datuk, for such an inspiring speech. So unfortunately, we've run a little bit over time. So maybe we'll just take a few questions, maybe one or two. So yeah, so one question from Jonan Ng. What are your thoughts on Sweden's approach on COVID-19?
Now, initially, see, most of the virus, if you are exposed to the infection, then you build antibody. So when you build antibody, then if the community has already been infected, then the antibody from the infection, if you have 80 to 90% of the community being infected, then if you have the antibody response, that will be a herd immunity. So that's very good. That's a theory. But again, this is a new virus. So the new virus, apart from SARS-CoV infecting our lungs, our pneumonia, etc., we also know that this virus attacked the endothelium of the vessel. And once it attacks the endothelium of the vessel with the cytokine surge as well as injury to the endothelium, then you have clots formation. This is the vocal tracts and clot formation. So if clots forms in the heart, then you get heart attack. And clots forms in the brain, you get a stroke. Clots form from the renal artery, then your renal failure. And so we have a few patients, that young patient, they have this clots formation. And during the postmortem, we realize that this is something new because clots formation is attacking the young population. Third is that there is an immunodeficiency response, whereby with the report from China, after the infection, the live virus, they really infected with the live virus, the antibody response after 8 weeks is only about 17%. In UK also they reported 70%. Here in one of our school, the toughest school, they have been infected. So 3 months later, we did the serology test, the antibody, only 20%. So which means if it's 20% live virus they've been infected with the live virus. So our question is, they can be reinfected again. That's number one. Second is the possibility of antibody in terms of, you know, if you give a live attenuated vaccine to them, will they get the build the virus, the antibody response? So it's not. Second is actually when you look into this virus, there is actually more than 3 strains, A, B, and C. A in Europe and in the US, B is from China, C is from the Asia, Indonesia, etc. And then there's mutation. There are about 22 mutations. Recently in July, they reported the D614G mutation, and this is a spike mutation. So now our question is, if there's so many mutations, whether the vaccine will cover all these mutations or not in terms of building response. Maybe the vaccine may work in US, but it may not work in here. We're here. But we don't know. We have more questions than answers. For example, recently there's actually been reported the Russian vaccine being registered, but we want to see the clinical phase 3 data in terms of the efficacy, in terms of response, in terms of safety, and how often do we need the booster? What is the antibody response? What is a lot of questions, but we do not have the data in hand. So maybe they have done it, I don't know, but we need the information before we can make a decision whether to actually buy the vaccine or not.
All right, thank you for your answer, Dato. So due to time constraints, we will not have time for any more Q&As for this session. But if anyone has any burning questions to ask Dato, feel free to type your questions into the Q&A function in Zoom, and the MBIOS committee will compile all of the questions and send it over to Dato after the event. So once again, Thank you so much, Dato, for making time for this event on a Saturday evening, despite your extremely busy schedule. And a big thank you as well to Dato's office for their kind assistance in making this session possible. Thank you.